Welcome back to the Wellness Script podcast, your source of truth for all things health and wellness. My name is Lauren O'Reilly. I'm a qualified pharmacist and your host for today. Today I'm joined by Jess Willow, a registered dietitian, certified fertility dietitian, an intuitive eating counsellor and founder of Willow Nutrition. Jess supports people through fertility, helps people with PCOS, now reframed as PMOS, with IVF, with assisted reproduction and women's health nutrition. Her work is both evidence-based and deeply personal, having navigated her own PCOS diagnosis as well as her fertility journey before founding Willow Nutrition. And today we're going to cut through the noise around fertility and what genuinely matters, what doesn't, the role that male fertility has to play, and how to support your body without blame, guilt, or over-optimization. Here's my chat with Jess. Jess, you are very welcome to the Wellness Script podcast.
Thank you so much for having me, Lauren. It's lovely to be here.
I'm so happy to have you. I've been following you for a while now and I've been obsessed with all of the information that you put out there. But I think a great place to start might be, what got you into this world of nutrition and such a specific area of it as well? You've had a really interesting journey.
Yeah. So I trained as a dietitian.
Mm-hmm.
So I trained as a dietitian in the UK. So I did an undergrad in human nutrition and then I did a postgrad in dietetics and masters in dietetics in Leeds and then Durham. So I kind of went a longer route, but I really enjoyed my studies and kind of always knew that I wanted to go into clinical nutrition. So work in a hospital, which I did. I worked in the UK for 3 years in lots of different roles, acute and community dietetics, and specialised in head and neck and critical care, head and neck cancer, and critical care nutrition. And absolutely loved it. I love working, as a multidisciplinary team and working in the hospital. And then I moved back to Ireland and started working in private healthcare in Ireland. And again, really, really enjoy that. But I've always had an interest in women's health. And particularly as I was diagnosed with PMOS, which was previously PCOS, very recently name changed. So I guess I have that kind of individual experience of kind of being on the other side of things. But we don't really learn a lot of that in our dietetics degree, and obviously especially in the areas that I was working in clinical nutrition. So that was always kind of on the back of my mind. But first I found intuitive eting. So I discovered that when I was working clinically, and it was actually Emer O'Driscoll, who I think is a previous person that came on the pod as well. So she's a good friend of mine, but she was practicing in intuitive eating, and I discovered intuitive eating, and I kind of got in touch with her, and I was like, "What is this? Like, can you tell me more about it?" And she sent me all of the information. We kind of had a chat about it, and it just seemed so different to how us as dietitians were taught at the time when I studied. So kind of moving away from weight as a focus or a goal of care, and looking at other kind of health goals or parameters that we are focusing on as goals of treatment or support for people. So that was initially where I kind of started, I guess, deviating away from like what I was doing in the hospital. And I always knew that I wanted to move into kind of like private practice or kind of look at running my own nutrition clinic, because I love that kind of face-to-face with people, and I guess kind of having that more individualized care and time with people. So I started kind of looking at intuitive eating. I ended up training in intuitive eating with Evelyn Tribbley and Elise Resch, who are the two dietitians who developed intuitive eating and started off with the research base around that. And I guess what intuitive eating is it's a 10-step framework that looks at, it's a self-compassion framework.
We need more of that.
Yeah, absolutely, especially in the world that we're living in at the moment.
Yes, definitely.
And moving away from weight as a focus, and looking at more internal cues, focusing in on internal cues of hunger and fullness, body satisfaction, looking at our relationship with food. So the relationship with food is a big one.
That's so interesting, because I think that's missing massively with the trends we're seeing at the moment. I cannot get over the number of prescriptions that I'm processing for weight loss injections, weight loss medication. And I certainly believe that they have a really important role to play in weight loss management and in population health and that kind of thing. But I do think there's a hugely missing piece that either there needs to be like a dietitian role before it gets to that stage, and also during that stage, so that there's a view and a treatment plan. Like I'll often ask people, has your doctor talked to you about like, you've been on this for X amount of time? Has your doctor talked to you about continuation? And then a lot of the time I hear like, oh, I'm going to stay on the low dose. So like, because I'm afraid that when I come off it, I'm going to put it all the way back on again. And like, that's like, that to me just seems like such a missing education step. Like there doesn't seem like there needs to be a clinical reason to stay on a weight loss medication if the initial huge, change to get to a healthy BMI has been achieved. Can we maintain that through nutrition, surely, or?
Yeah. No, and I 100%, I'm just like, the GLP-1s is such a huge, it's an influx. And like you said, there is a time and a place for them with some people, but not the number of people that we're seeing coming through on GLP-1s.
No.
And I guess that the long-term data that we have on GLP-1s is that as soon as you stop a GLP-1, the weight does creep back up, and you will get back up, if not higher, to the weight that you were prior. And I don't think that's discussed with people enough before they're started.
I don't think so either.
And I think like that, even though I work in a weight inclusive, approach, obviously I discuss weight loss with clients a lot, and people will have a desire to lose weight. And I do work with people who are on GLP-1s because I think you cannot work in healthcare without working with people that are on a GLP-1, because it's just so common at the moment. But like that, like there are specific nutritional implications when you're on these medications, such as you're going to lose significant amounts of muscle mass regardless, because you're going to lose fat mass, but you're also losing muscle mass. So like nutritional support during these times is really important to try and support your protein intake, make sure you're not at risk of nutritional deficiencies. And some of the people that I would be seeing that are on GLP-1s are maybe on a GLP-1 because they want to lose weight or have been told that they have to lose weight in order to get pregnant. And then that comes with so many other issues,
right? Because
we don't have any robust research or data to show that it's safe to be on a GLP-1 when you do conceive.
True. Yes. I was only reading the information about this the other day. Yeah, it is really interesting.
So I guess I've kind of gone off on a tangent, but yes, with the GLP-1, so that's in the world that we are in, the intuitive eating framework is really important, I guess, for I think everybody, really, regardless of what your background is, what your comorbidities are, where you're coming from, what your health goals are. So I kind of started working in that. And then when it came to the time 6 years ago now that I was thinking about trying to conceive with my now nearly 5-year-old, when I was diagnosed with PCOS, which is now PMOS, I did not have a positive experience. I was diagnosed when I was 19 and very, very negative experience. Unfortunately, did seek further review when I was a little bit older, but again, slightly better experience, but still just stay on the contraceptive pill, thinking about having kids a little bit earlier than, just to have that in mind. So in the back of my head, even though I had looked into the research and knew more about it than I did when I was initially diagnosed, you still have the thought, well, I've been on the contraceptive pill since I was 16, 17.
Yes.
I don't know if I have a period at all, or if I do, is it going to be regular? I don't know if I'll be able to get pregnant. And I was going into this trying to conceive my first child petrified.
Yeah, I was going to say, you must be so anxious.
It must have been so anxious. If this is going to happen or not. Luckily, I did conceive and obviously have two kids now. Yeah. But that was really when I was kind of starting to look into more information around managing PCOS, PMOS, and trying to get credible information out there. And yes, there is a little bit, but there's more information out there from maybe people that are not as qualified as they should be giving advice. And some of the advice is absolutely valid. And some of the advice maybe not as, as necessary or evidence-based as it should be.
Yes.
So that was when I was like, right, okay, I am really interested in this space. And I think that there is an area that, needs to be addressed and supporting people like me who just are a little bit, don't really know where to go and would just want somebody to support them going through the process. So I then did further fertility nutrition training with the Early Nutrition Alliance, which is an Australian-based team of fertility dietitians that run training for dietitians specifically.
Okay.
So I did that course, became a certified fertility dietitian, and then started working in intuitive eating and fertility. And I was like,
wow.
oh, this is my jam. This is where I want to be.
As a pharmacist, the question I get asked most often this time of year is what to do about hay fever. And one of the things I see all the time is people reaching for the same decongestant nasal spray week after week, not realising that it can actually make symptoms worse over time if you keep using it. That's where Otazan stands out. Otazan Nasal Spray Forte and Nasal Wash are natural, drug-free alternatives, so there's no risk of that rebound congestion that you get with regular decongestant sprays. I use the nasal wash daily myself to cleanse my nose of any irritants, and I bring the nasal spray on the go with me. They are part of Otazan's full family wellness range. Otazan is an Italian natural wellness brand that's been around for over 30 years. They are ear, nose and throat specialists that combine traditional herbal knowledge with modern research. And today their products are used and trusted in more than 30 countries around the world. And you'll find them in pharmacies and health stores nationwide. That makes a lot of sense, especially with the crossover with PCOS, PMOS, and how there's a weight related factor there where, you know, women are often told, you know, lose weight because there's a metabolic element to PCOS, which maybe you could explain kind of how that kind of works. Like, what is the connection there between, I suppose, the intuitive eating side, the fertility, and PCOS as well?
Okay, so I guess with PCOS, so that was renamed 2 weeks ago, a week ago, to PMOS. So it was polycystic ovarian syndrome. It's now been renamed to polyendocrine metabolic ovarian syndrome.
Lovely.
Still trying to get my head around it. It's a mouthful, PMOS. It was time to rename it. The name itself, PCOS, was just so misrepresentative of actually what the condition is. So obviously many cysts, cystic, cysts on the ovaries, and a syndrome, collection of symptoms. But you do not need to have cysts on your ovaries. They're not even cysts, they're immature follicles. So lots of follicles on your ovaries. I think cysts is quite a scary word for people to hear. They're like, oh my God, what does that mean? Like, are they, does it need to be removed? Does it need to be removed? What? It's quite scary to be told that there's cysts on your ovaries. But you don't need to have cysts on your ovaries to have what was PCOS. And that is, exactly. And that is, really, really confusing for maybe clinicians who are saying, oh, well, this person doesn't have cysts on the ovaries, so surely it's not PCOS, it must be something else. And also then for women that maybe were diagnosed that don't have cysts on their ovaries, to be told they have PCOS. And they're kind of like, well, what does that mean for me? Am I less, am I not fitting into that criteria as much because I don't have the cysts? How do I kind of navigate this? So over the past 13 years, they've been campaigning for a name change. So thankfully it's happened. So PMOS, so it's looking at polyendocrine, so lots of different hormonal factors in place. So mainly it's insulin resistance that's occurring. So that's the main driver in PMOS, that 85 to 90% of people with PMOS have insulin resistance, and that what causes the difficulty losing weight, the significant cravings, the energy dips, and then the insulin resistance then leads to the high male androgen hormones. So that's the other kind of hormonal issues that we see, the high male androgen hormones, which can cause some of those physical symptoms that we see, such as like the excess hair growth on the face or on the back or on the chest or the navel area, which is really a massive struggle for women because it's very apparent. It's really hard to navigate, especially if you're quite young. Like you don't really know how to manage that. It can lead to cystic acne, again, on the face, on the back, on the chest, sometimes thinning of hair on the top of the head as well. So I say it's not just like, you're brushing your hair and you're like, oh, shedding. It's the top of the hair, the thinning of hair, and they're kind of that male androgen that's kind of pushing that. And then, you have kind of the LH, so your luteinizing hormone shifts up as well. Sometimes you can have a false reading of a high AMH, so your anti-Müllerian hormones. If you do have lots of those follicles on the ovaries, it pushes out more of the AMH. So sometimes women are like, oh, great, I have a really high egg count, because that's what that AMH tells people. Exactly. Yes, how many eggs they have. Yeah, it's actually kind of a misrepresentative increase in the AMH because they're immature. They're immature. They're not going to grow into, releasing the egg. So it pushes out more AMH. So there's lots of different hormones at play. So that's the endocrine. Then the metabolic side of things, and this is kind of on the back of a lot of those hormonal changes and, I guess, irregularities.
Yeah.
And that is, so we see like the metabolic, we see obviously cardiac issues. So we see like high lipid profiles, high cholesterol, things like that. We see increased risk of gestational diabetes when you do get pregnant. If the insulin resistance is present, higher risk of developing type 2 diabetes, again, because of the insulin resistance. And we see things like sleep apnea. We see things like if you're having irregular periods or missing periods, an increased risk of endometrial cancer because we're not shedding that lining as frequently as we should be. And that can increase the risk of endometrial cancers. So lots of, and then obviously the fertility issues. So lots of things going on. And then ovarian, because they are still, it's a factor. The ovaries are still involved because obviously they're pushing out a lot more of the LH, they're pushing out a lot more of the AMH and obviously the androgens as well, the male androgens, which the ovaries are pushing out too. And then it's a syndrome. So collection of symptoms, lots of different symptoms. So that's the name change. The diagnostic criteria still remains the same. So in order to be diagnosed with PMOS, you need to have 2 out of 3 criteria. And the 3 criteria are irregular or missing periods, raised male androgen hormones, and or the physical symptoms associated with raised male androgen hormones, which we mentioned. So you could actually have a normal testosterone, but have the hirsutism, have the thinning of hair on the head, have the cystic acne, and they would be signs that actually the male androgen hormones are at play. And then the third one is the cysts or the follicles on the ovaries. We sometimes do look at AMH as well as kind of bringing in instead of the follicles on the ovaries. So it's either use the AMH or use the internal ultrasound to look at the cysts on the ovaries.
Wow. I'm listening to this and it's like, how daunting is this for people? Do you know, like when, if you're, say whether you're a teenager, you mentioned 16, 17, you went on the contraceptive pill, but to manage symptoms indefinitely kind of at the time, and then like you're taking in all this information as potentially a young girl or young woman as to your whole future fertility. You're not maybe thinking about having kids yet, but you know that this is kind of something that's going to affect it in the future. But like, I think that it's really important for people to realize how much we can influence if we know sooner, and if clinicians know to recognize the symptoms now that we have a better definition of it. So from that perspective, like, let's take a journey that would have been better for you. What could that have looked like had you known at 16, 17 what we know now, or what you know now?
So I was diagnosed at 19.
Oh, 19.
So I was on the contraceptive pill before that, for regular cycles, but I wasn't diagnosed until I was 19, 20, I think. Yes, that's a really good question. So I was at university. I went to university in the north, in University of Ulster. So it was kind of in the NHS I was diagnosed. Obviously I was in second year of uni. I was having a great time for myself, and probably wasn't looking after myself as well as I should have been. But when I was told I had PCOS, it was an older male gynecologist told me I needed to lose weight. I said I felt like the contraceptive pill was driving up my appetite. He disagreed with me heavily and said he wouldn't take me off the pill, or he didn't advise that I stop the pill, and that I needed to think about having children earlier in my life, around 23.
Gosh. Oh my God.
I was like, right, okay. And there wasn't as much. I think we talk a lot more around PMOS, fertility issues, our menstrual cycles. It's conversations that we're having now, which is amazing. But like back then, make it sound, back in my day.
No,
but back then it wasn't. Like, I was like, what is this? Like, I have no clue. I was like...
And you're being told to have kids ASAP. Like, that's a very strange thing to be told. What if you want to, fine. But if it's not something that... No, but exactly. But if it's not something you're thinking about and you're being told this, like, that's very scary. And
that was all I was told. Lose weight. Think about having kids earlier. Stay on the pill. That was it. So... at that time, what I wish I had been told was lifestyle and nutrition is first line advice for managing PMOS. And that is the case. So even though I was studying nutrition at the time, but I didn't know. I had never heard of a PCOS before, really, kind of hear it being thrown around. I wish he had offered me a referral into a dietitian.
Yeah.
Yeah. And
Yeah.
actually listen to me a little bit more. Now I was young, but like, and I didn't advocate for myself. I was like, okay, yeah, no, that's fine. He's the doctor. He knows best. I was like, I'll come back to this in a few years. And then I did seek a different gynecology referral when I was a little bit, a few years later, when I was actually working as a dietitian at the time.
Yeah.
But again, the advice wasn't much different. It was stay on the contraceptive pill, we'll run your bloods and just check them. And then when the time comes that you maybe want to think about starting your family, like if you have issues, come back.
Okay. And I know it's very personalized, which is why you go specifically to see a dietitian yourself. But are there general things that people could follow if they have been either diagnosed or suspected diagnosis, or are in that kind of area? Yeah.
Yeah. So I think once you know that you've been diagnosed with it, because sometimes like irregular periods or the follicles on the ovaries, it could be something else.
That's true.
So it's really important. And again, with PMOS, it is important to exclude other potential causes like thyroid conditions, like hypothalamic amenorrhea, which is your missing periods due to underconsumption, overexercising, things like that. So it's really important that you're excluding all other causes first. But once you have been diagnosed with PMOS, there are, like, everybody's symptoms are quite different. So we would look at the symptoms, we'd look at the bloods, we'd look and see, kind of what each person's goals are and things like that. But yes, it is, again, like I think with nutrition, we always come back to it. It is kind of like a Mediterranean style diet. It is healthy eating, which I think when people hear dietitians say that, they're like, oh, snore.
Yeah.
Like, that's so boring.
Food pyramid or something comes to mind, like,
oh gosh, don't. But it really, it's regular meals are so important with PMOS. And I think for some reason, there are kind of things about intermittent fasting and going keto and, cutting out gluten, cutting out dairy, whatever it is. But it is really like paring it back. Okay, are you eating regularly? If insulin resistance is present, if we're going for big, long gaps between eating, then that's going to cause significant energy crashes. It's going to cause cravings to shoot through the roof. We want to try and keep our blood sugars as stable as possible when we have PMOS.
Right. Yeah. Okay. And then because you're going hungry and then you're flooding the body with food, your insulin,
it's going to shoot through the roof.
Up, and then you're getting more inflammation in the body. Is that the kind of pathway that you're thinking about?
Yeah, 100%. Okay. So like our insulin just isn't working as efficiently as it should be. So the insulin resistance, like, it's slowing down. It's not opening the cell doors to let the energy from our food in.
Okay.
So therefore glucose is stacking up in the body. But then our brain is saying to the pancreas, right, actually, we need more insulin because there's loads of glucose here. So it throws out more insulin. Okay. And then that insulin is saying, right, okay, we need more glucose because there's loads of insulin here. And it's just, you're peaking and troughing. And then the high insulin is then what causes, it signals to the ovaries. And that's what causes then ovaries to throw out testosterone. Okay. So it's kind of the core root of starting to support people with PMOS is looking at that insulin resistance piece. Okay. So it's looking at starting your day with a good kind of protein-based, carbohydrate, colourful breakfast. And making sure that you're starting your day off well, trying to not leave longer than kind of like 4-hour gaps between a meal and a snack where possible. I mean, we don't, sometimes it's out of our hands, but really kind of trying to plan a little bit ahead. We want to be including whole grains. So we don't want to cut carbs out, but sometimes the proportions and the quality of the carbohydrates that we're looking at is important. So we want carbohydrates that are going to be higher in fiber, slower released into the blood to enable your body a little bit more time to get those insulin out and kind of open the cell doors. Yes. It doesn't have to be all of the time. And I think that's sometimes where people with PMOS come in and they're like, oh, well, I was told I could never eat sugar and I'm just really dying to have a bar of chocolate with my cup of tea.
Oh,
it's like, you can, but it's what you're doing most of the time. So, and I kind of say, like, if you're pairing, your bit of chocolate with maybe some nuts and seeds or a nice yogurt with some protein in it, that's going to be a lot more, supportive of your blood sugars and your energy levels rather than maybe just eating the bar of chocolate by itself, if you're doing it frequently. So it's looking at balance, it's looking at being realistic and practical. And then there are kind of other foods, that we can look at adding in from the inflammatory perspective. So there's kind of a few pillars we're looking at. We're looking at the insulin resistance piece. We're looking at kind of the low-grade chronic inflammation piece. Okay. So again, we'd be looking at like those healthy fats, like your nuts and seeds, your omega-3s from your oily fish, or supplementation if you don't take oily fish in your diet. Okay. We'd be looking at like extra virgin olive oil, your avocados. They're all going to be anti-inflammatory in the body. So that's really nice and really important as well if you're kind of looking at your egg quality from a fertility perspective.
Okay.
We'd be looking at sleep. So women with PMOS have a higher likelihood of sleep disruptions.
Okay.
And so we'd be looking at the quality and the quantity of sleep. And we also know that that's, again, really important in fertility, because if we're not sleeping well, our stress hormones are higher, also impacting on our dietary preferences
Yes.
or choices the next day. Because if you're erect, you're going to be preferring, caffeine, sugary foods, quick acting energy that's going to be giving you that boost. So looking at the quality and the quantity of your sleep, we would look at activity and exercise as well, stress management. So it is a very holistic approach.
Yes. And you didn't mention weight at all there, like that.
Yeah.
You're focusing on what's I'm not saying it doesn't have any role, but that you're focusing on what you're putting in. How can I make this more of a whole food based diet? How can I do exercise that helps to support my inflammatory kind of process in my body? And maybe some forms of exercises are too stressful. I don't, I would imagine, like, if it's too intense and you're going through a period of inflammation, that you need to find something that's right for you. And I think there was such a big shift towards not eating or narrowing the window as small as possible, which I saw and was, to be honest, a little bit influenced by. I started to think that, that maybe it is better if we don't have breakfast, or if I stop eating at a certain time or whatever, for like gut health or whatever. And that wasn't a helpful behavior for me personally. Like I always I've always liked regular meals, and that kind of shift, I realized it started to get in on my head. Now I'm just back to eating
fueling your body in the way that you need,
listening to my hunger cues,
100%.
So like I think that you can get caught up in the noise of it all, but definitely getting a tailored kind of plan. Maybe that's good for some people who have a very specific issue, but not unless you actually need to go without food for long periods of time. And then you mentioned fertility in relation to PCOS, but people come to you for fertility reasons outside of PMOS as well. So talk to me about that. Like, how big a role can nutrition play in fertility journeys?
Yeah, I love fertility nutrition. I actually just finished, I redid the course that I initially trained in, and I just finished it yesterday, actually.
Oh, amazing.
So I went back as an alumni, because research is forever evolving, as I'm sure you know, but especially in nutrition, and even more so in nutrition in women's health, in fertility, because it's a relatively new area, really. And we're now starting to study women more, which is amazing. So like that, with kind of the intermittent fasting or time restricted feeding, a lot of the initial research that came out was actually based on men. And we are a lot more complex than men. There's a lot more hormonal interplay coming into place. So like, we need the research on women.
Yes.
And so with the fertility side of things, we know that nutrition and fertility, like, I'm a dietitian, I work in fertility nutrition, but I always do say it's one piece of the puzzle of many varying different components. But it is a piece of the puzzle that you can have autonomy of. You can make changes on that are not only going to improve your chances of conceiving, but are also going to improve the health of your future child, hopefully. And also like your long-term health, like your overall health. And I think it's so important to put in here that it is both partners.
Yes.
And I know we were going to talk about like male factor fertility, but it is both partners. And like, we know that it is equal components, or, male and female factor fertility are equally, have equal
weight, kind of, or importance.
Exactly, equal importance in regards to the future genetics of your child, of the embryo. Like, it's made up of both genetic materials.
Yeah.
And yet 85-90% of the people I work with in fertility are women.
Yeah. Doing the work for the couple, I suppose, even though it doesn't work like that. Like, I can't do 85% of the work because I don't account for 85% of 50% of the equation.
Generally, if you're, obviously, looking at both, if you're kind of in a heterosexual couple, it is 50%.
Yeah.
And yet, like, the woman, and I do support men as well in, the male factor fertility, but it is equal components. And yes, there are, like, obviously when we're looking at the woman, we're looking at, a lot of the time there may be obviously other comorbidities in the same way that there may be with the man. And we're looking at the egg quality, and we're also looking at the uterine environment, because obviously the woman is going to be carrying said baby.
Yes.
However, the genetic materials of that baby is also 50% of males.
Yes.
The sperm health. So I think, really important for both. But we know that egg quality can be improved with nutritional intervention. And there was a really large cohort study, I think it was 2017, I could be wrong on that year, but a large cohort study looking at 17,500 women who it showed that making 5 or more dietary changes increased your chance of ovulatory fertility by 68% or 69%, something like that, the high 60s.
That's amazing.
Which is amazing. Now, these women didn't have any, they've kind of followed them over a retrospective period. But they found that making those small changes can significantly impact on your chances of conceiving.
Wow.
So that's really important. And then we also see with male factors like sperm health, sperm regenerates every kind of 74 days, give or take. So with the eggs, obviously we are born with all of our eggs, and that number will start to slowly decline as we get a little bit older and we ovulate each month, or but the quality of the eggs also starts to decline as, unfortunately, we get a little bit older as women. We kind of have a shorter timeline than men.
Yeah.
And especially in this day and age, women are starting to have families later in life for lots of different reasons. And so the average age for a woman having her first child in Ireland at the moment is 33 years of age. But the majority of women I see are over 35, 36, 37, 40, 41 for fertility, because unfortunately a lot of people will come to me after they've already been on a fertility journey for a few years.
Okay.
I wish people would come to me at the very beginning,
alongside or before that.
And I do have some people that book in and they're like, oh, just thinking about starting to conceive and just want to get it once over, look at my bloods, look at my nutrition, my lifestyle, just make sure I'm tip top and on the right supplements and perfect. And sometimes we'll get the partner in as well.
Okay.
But generally it is the woman. And sometimes I guess when I'm working with a woman for fertility, after a few sessions, they might then get the partner booked in. And he might do a one-to-one if he wants. But sometimes it's like, can I just ask you about his supplements? Can I ask you about his, should he be drinking alcohol? He's smoking, is that okay? And they're asking the questions for him. And I'm like, he really needs to be here. Sperm regenerates. So we see it so clearly when we have that time to support the man. We see it so clearly on paper. If they've had a sperm analysis, say for example, as baseline, and it's not great, so we look at kind of the quantity, the way it swims, and the shape of the sperm, as well as pH and viscosity and things like that. And if you work on your nutrition, work on your lifestyle, cut out alcohol, smoking, vaping, obviously we'd look at kind of testicular health and things like that and making sure we're supporting that. And this is why men don't want to come. I understand they don't want to talk to a woman maybe about their testicles. It's fine. But we just know that it's sperm health is so receptive to nutritional lifestyle changes. Then if you get that sperm analysis rechecked again 2 or 3 months down the line, you see the improvements.
That's a short window, really, because you can influence it so much. It's being regenerated as opposed to, as you said, the eggs, which is we're born with as many eggs as we're ever going to have, and they just deplete from there. Whereas with sperm, you can increase the count.
You can increase the count. Whereas with eggs, we do see, we would say a minimum of 3 months for women in making nutritional lifestyle changes. There's no test that we can do to test the quality of our eggs, but we obviously would look at hormonal profiles and things like that, and make sure that we're kind of trying to balance those as much as possible, and looking at progesterone to see if you're ovulating. But there's no test as such in the same way that we can test sperm. So we'd kind of say minimum of 3 months for a woman to have kind of an improvement in the quality of their eggs, if that's really what we're focusing on in preparation for fertility treatment, for example. So there's lots of changes that we can make.
And
both.
In general, I know it's very specific. In general, are there things that you see time and time again that either women or men or both are doing, I'll say in quotation marks, wrong, or that we could do better? So I think main ones. So when a woman, and I'll say the woman because that's who usually comes to me, gets in touch, and maybe they're further down the line of kind of their fertility journey, supplements is a huge one. So they may be taking nothing. There's so many times that women come to me and they've been on a fertility journey for a while and they're not even taking folic acid. Oh, wow.
Okay, let's look at that. Or on the flip side of that, they're taking everything.
Yeah, I
And
see. I actually see a
you
lot of
probably
that.
see that.
Yeah,
Yeah, yeah. And
yeah.
you probably see massive
And
big
nearly
long
taking
lists.
like two products that are both
Doubling up.
multi, and they're doubling up on stuff which can be harmful as well.
Absolutely, yeah. So
Mhm.
like, obviously, if you're doubling up, cost implications,
Yes.
like supplements are expensive,
I know.
a lot of money.
Mhm.
And if you have both partners on supplements, because the woman is normally then telling the fellow what to take,
Yeah.
very expensive. And doubling up on certain nutrients, which can actually be detrimental,
Yeah.
can interact with maybe medications that you're prescribed.
Definitely, yeah.
And also in the wrong forms of
Mhm.
nutrients. So actually, you're just wasting your money because
Mhm.
you're not going to be absorbing the form of the nutrients that you're taking.
Sure.
And also, there's more research coming out now, in particular, kind of on DNA fragmentation. So the DNA within the sperm head,
Okay.
that taking too many antioxidants can actually damage the DNA even more.
Oh, wow.
Yeah. So
Okay.
some of the kind of the fertility doctors are talking about that now, and we have research coming out to show that it's all actually about the balancing out. So sometimes, like if somebody has a high DNA fragmentation, which is a completely different test altogether from the semen analysis, and you could have a normal semen analysis in male fertility,
Yeah.
but actually there'd be high DNA fragmentation. So the DNA is damaged in the head of the sperm.
Okay.
And that can be, it's looking at kind of the core root of what's causing that DNA fragmentation. So sometimes it's treated with antibiotic treatment.
Okay.
Sometimes it's looking to see if there's any damage to the scrotum or the testes.
Okay.
And then sometimes we would look at if the DNA fragmentation has been confirmed, high dose antioxidant supplementation for a short period of time. So kind of for that 2 months or 6 to 8 weeks. But sometimes if men are taking that, if they haven't had a DNA fragmentation test done,
Yeah.
and maybe their DNA fragmentation is quite low, then that's actually going to be damaging the DNA even more.
Oh, okay.
Yeah.
Because it's not necessary.
It's not necessary.
What's an example of an antioxidant? Just so people can...
So antioxidants. So we would be looking at like vitamin C and vitamin E.
Okay.
So like everything we've heard of.
Yeah.
Like,
so people might be taking high doses of
high
those.
doses of those.
Okay.
Yeah.
Okay.
There's also like antioxidants that we'd be looking at in like fertility. CoQ10 is a common like supplement that people would take.
Especially in fertility, I see that an awful lot. So potentially people could be taking that unnecessarily and also to their detriment. Okay.
Yeah,
okay.
we're taking too much.
Okay.
And then like zinc and selenium and things like that. So
yes, those are all of the hot ones that people come in looking for fertility, but we maybe shouldn't be supplementing those blindly.
In very high doses.
In very high doses.
So if it's in like a multi or something like that, that's fine. Don't be worrying about that. But if we're supplementing in very high doses of those
people
antioxidants,
do ask for.
Possibly,
yeah. Okay. So those are the ones. Yeah. Anything, I suppose, in a high dose, it's almost like you're doing targeted treatment without any idea of what the target is. Yeah, exactly.
Yeah. 100%.
Okay. That's interesting.
This episode is sponsored by Elav Skincare. Elav is an Irish skincare brand whose sensitive skincare story started in 1934, so there's over 90 years of skincare expertise behind everything they do. It was founded in Ireland by the Gardner family apothecary, and 4 generations of the Gardner family have helped people with anything from minor irritation to sensitive and reactive skin types, which are conditions I come across all the time as a pharmacist, and something that I know so many of you are navigating too. Today, their award-winning skincare innovations are at the forefront of dermatology, free from sulfates, alcohol, perfume and artificial colours, ensuring that they leave in what's suitable for all skin types, which is why for years I've been happy to recommend their products to both my patients and my community alike. With Elav products, you give your skin what it needs and not what it doesn't. You can explore the full range at elavskincare.com and in retailers nationwide. And as a listener of the Wellness Script podcast, you can use the code WELLNESS for 20% off online.
And even like the fact that the fact that you're saying that when you know about the DNA fragmentation within the sperm through the test that it's treated with an antibiotic, that's so interesting. Like, because how long could somebody be trying for both the woman and the man, and maybe the woman thinks it's her, and actually his course of antibiotics to treat that very specific problem that you wouldn't have known only for the testing was the thing. And then maybe they conceived then, or, wow.
Yeah. And I've had couples who, I actually had a girl last week and they'd been on a fertility journey for 4 years.
Yeah.
And apart from the partner having the semen analysis, like day dot, like after, their 6 months of whatever, of trying to conceive, he hadn't had any other investigations and they were looking at everything for her.
Oh, wow.
Like, this is like, it's both. It's instead of, I think it's what's wrong with her or sometimes what's wrong with him, it should be how can we support this couple together to get there? And, what are we not looking at? And I think often it is, the onus is placed on the woman, and it's the woman that's doing all the research. It's the woman that's changing everything.
Yeah.
And I'm not saying for everybody, but for the majority I see, the man changes very, very little. He takes the couple of supplements that he's been given by her in the morning, and that's it. Everything else is the same for him.
Yes.
And she's cut out caffeine. She's cut out alcohol. She's, cooking everything from scratch.
Yeah.
She's, taking all the supplements, doing all the research, seeing all the people.
Yes.
And,
yeah.
he's just sauntering away.
Yeah. And maybe not getting the right advice, maybe well-intentioned
Possibly,
as well. Because I think that's hugely important when it comes to fertility, that there's an understanding that it is both people. You can influence things. And the question that I have for you, Jess, is like, and I don't know if there is a straightforward answer, is there such a thing as like true infertility, like, or is there almost always something that could be addressed?
That's a really good question. A lot of I guess doctors would say it's subfertility rather than infertility. I think infertility sounds so fine.
Yes.
It's like, oh, you're infertile.
Yeah.
Good luck.
Yeah.
But I think subfertility is a nice term to use.
Yeah.
It's a little bit more compassionate, and it's really kind of saying it's not infertility, it's unexplained infertility, it's unexplained subfertility. So you need to look at the core root and keep investigating. I think in a very small percentage of people, we just don't know why.
Yeah.
But we're seeing it more and more now, and I'm not saying this is the cause of the issues for if people have been struggling to conceive and they're thinking why, but we're seeing more like silent endometriosis now being diagnosed, and that is a huge driver of subfertility or difficulty trying to conceive. And you may obviously, a lot of people with endometriosis will have significantly apparent symptoms, a lot of pain, heavy bleeding, very, I guess, symptoms that are very hard to manage on a day-to-day. But then there are some women who will have no symptoms, but they're not getting pregnant, and they can't figure out why.
Wow. Okay.
Yeah,
so you could have endometriosis and not know.
Yeah.
Okay.
Yeah. And I've had a few clients come through with that. Like, they've been tested for everything, and then they go in and do the laparoscopy, or they'll, it doesn't often come up on the ultrasound when it's silent endometriosis, that you can use ultrasound techniques now to diagnose endo, but gold standard is unfortunately laparoscopy, keyhole surgery.
Yes.
So they've kind of sent them for an investigative laparoscopy, and they found endometriosis everywhere.
Wow.
And no symptoms.
Okay, so it's like if you had, say, really heavy period, right, really a lot of pain, like you would, someone at some point would have said to you, say, like, that could be endometriosis, to get it checked out. But if you hadn't had any of those, you wouldn't have had any reason. And I also think it's really interesting, like, if whether you're on a fertility journey or not, like, to have undiagnosed endometriosis, and you may never want kids, but you would only find that out through going on a fertility journey, is really interesting, because surely that affects your long-term health, to have this inflammatory process going on in your body, like potentially contributing to something else that you might develop later in life, that you only found because you're like, I'm trying to conceive and I haven't been able to. If somebody was never trying to conceive, they never would have found it. Out, So I think a fertility journey is actually a health journey, like for your long-term longevity, health and well-being. And I think that when you look at it from that perspective, and when we think about fertility, even if it's not something we want to, action today, let's say that we're not trying to conceive, I think people who are younger, like in their even early 20s or in their 20s, should think about their fertility health with an exploratory mindset, just to see, what's my body like, what's my cycle like for a woman, what's for a man, what's my sperm like, and actually am I doing things that, whether it's alcohol or caffeine or pre-workout or whatever it could be that in your lifestyle that's maybe like affecting your health in a negative way, like address that just for your long-term health. And then down the line, when it comes to trying to conceive, you have these healthy habits that are going to serve you in so many ways, I think. Like it's a holistic view, because then when you get to the point where you're like, oh, like we really want to try to have a baby right now, like it's so much pressure. So I think that if people were younger and knew more about it, like we can, like obviously you can influence it at any stage, but it would just be really nice to be proactive. I think
we need to teach it in schools.
I think so.
100%. Like, you're told what a tampon looks like and a pad looks like. The boys are sent away, and then you're told how not to get pregnant.
Exactly.
You're actually not really told, like, that your menstrual cycle is so important for your health, like so important. what what's normal for people, what's not normal, and then looking at fertility and looking at overall health and the importance of actually menstruating monthly, and how that's important for your bone health and for your psychological health, and for your reducing the risks of certain cancers and things like that. And I just think, and also like the contraceptive pill and how that can impact on your overall health and deplete you of certain nutritional issues as well, or nutritional deficiencies. And like, again, you're coming off the pill and then you're trying to get pregnant straight away without even maybe ever getting bloods checked. So I think more education younger is a really good idea.
Definitely. And because you mentioned the contraceptive pill and depletion, tell us about that. Is there a common nutrient depletion that you see with being on a contraceptive pill for a long time, or?
Yeah, so it can, because like your body's processing the medication itself, and you probably know more about this than I do, and kind of the pharmacological impacts of it. But it can then cause depletions in certain B vitamins, in zinc, in magnesium. So we would often, I guess, recommend that when you're coming off the pill, you're getting your bloods checked, you're getting your nutritional bloods checked, obviously not getting your hormones checked straight away, because it's going to take a little while for obviously the pill to get out of your system, and give yourself kind of a minimum of 3 months, even 6 months if you can, to then get the bloods checked maybe a few months after coming off the pill. Look at your nutritional status, look at your hormones, find out what actually your menstrual cycle is like, and then look at kind of, okay, let's start trying to conceive now. I know that's it's not possible for a lot of people. We don't really pre-plan often like that, but where you can, and I think it's having that knowledge around that. Like when I came off the pill, however long ago, gosh, I didn't have a clue about any of that.
No.
I'm a dietitian. And now I'm like, oh, such an idiot. How did I not know that? So I think it's really important.
I agree. And I think it's the bloods piece is important too. Obviously, like there's no need for everyone to be getting their bloods done all the time. But when at certain stages, when something has changed, or, we've been feeling a certain way for a long time, whether it's fatigue or we're noticing changes in our skin, our hair, our nails, like paying attention, I think in terms of wellness, paying attention to our body and the signals that we get from it, whether it's, physical or how our mood is, how we're physically, like all those things can be an indication of nutritional status, hormones, and I'm just such a big advocate for that. And I see like the kind of band-aid approach so often in pharmacy, where we're treating something like pain or, frozen shoulder, and it's something to do with hormones in the menopause, or, and it's just like exploring why something has come on suddenly or over a period of weeks or hasn't disappeared, I think is really important, and something that we need to like definitely prioritize from I think that is true self-care. Like it's great to have a bubble bath, and it's great to do
the face mask,
yoga, but really self-care, like, and the reason I mentioned fertility as well is because that's kind of almost not really self-care. That's kind of a goal that you have together as a couple or whatever, or sometimes solo. But that's a goal. But what about you? And what about actually just looking after yourself to look after yourself? Women tend to have more autoimmune conditions than men. Like, let's be curious about what's going on in our bodies and see why that might be, and not from a blame perspective either, like, oh, you should be doing this, you should be doing that. But even me, like I'm always learning, and you said that as well, you're a dietitian, some stuff you're like I'm always just asking all myself the questions sitting in this chair. I'm like, so what do you think about this?
Hey, if you're loving this episode, do me a favour and click subscribe. It helps the podcast grow and helps me to keep bringing you conversations like this one. Back to the episode.
But like, if someone's listening just today and they're just thinking, what could I do? Let's say if they're on a fertility journey, or just thinking about future fertility, what are things that we could generally adopt to give ourselves the best chances, I suppose?
Yeah. So I'm not saying come and see me, but I really, really do think that anybody who is thinking about trying to conceive, either as a couple or individually, really should get a consult or some time with a dietitian who works in women's health or fertility. Even more so if you have any hormonal conditions, any comorbidities that may be impacting or may impact on your fertility or pregnancy outcomes.
Okay.
Really, I think just to get that once over.
Even before you start trying, like
Even before you
no
start
problems
trying.
identified.
100%.
I think that's better for the relationship, isn't it? Because you as in you're not going through this period of it's very difficult to go through. So if you can get ahead of something, or if you can identify something early, and maybe there's nothing, maybe you're fantastic.
There's always a few little tweaks that we can make, and it's all about optimizing. And like it might, and I have people that book in, they're just like, I just want to get a once over, just make sure that I'm, at the right place. I want you to just, I've got some bloods checked. I want you to just look at my supplements, make sure that that's okay.
Yeah.
Do a little bit about nutrition, and I just have a few questions, and they'll come to me with like a list of questions.
Yeah.
Fantastic.
Excellent.
And then they can go off and they just know, right, box ticked. That's grand.
Yes.
And it just does, like you said, relieve that stress or pressure or the other kind of potential question mark over that.
Yeah.
That would be one, if people have the resources to do it. And amazingly now with a lot of Irish health insurance, your dietetic appointments are part covered.
Excellent.
So, that's a massive thing for people. And then the other thing is, if you just want to get started now, is like, I am a big one for sleep.
Yeah.
I'm sitting there chronically sleep deprived because I have a baby at home that won't sleep. But where you do have the ability to manage your own sleep, not always possible, but where you can, sleep is a huge one.
Okay.
Like obviously not nutrition focused, but still holistic and for both partners. And we do have research to show that like lack of sleep can negatively impact on fertility outcomes for men and women. So the sweet spot kind of is 7 to 9 hours per night of good quality sleep. Okay. And we just know that will improve your overall health outcomes. It'll improve your hormonal support. Like that's when our body regenerates.
Yes.
It'll improve your relationship with food.
Yes.
It'll improve your food choices. It'll improve your ability to move your body and do some activity. So it just kind of ticks so many other boxes. Yeah. And like the amount of people that I see, and me guilty included, where we're, buzzing around late at night, we're getting into bed, we're on the phone then for another hour scrolling. Yeah. And like I'd say to people, like, what's your hour before you're going to sleep looking like?
Yes.
What is that routine like? And they're like, oh sure, I'm sitting in the bed on the phone scrolling. Absolutely nothing. And I know I shouldn't be doing it. And we all know we shouldn't be doing it. And it's really hard to try and break. So I often look at like a kind of a bedtime routine. And like we're gonna pare it back to like we're children again.
Yeah.
And we need a bedtime, we need a prompt of when to go to bed. We need a nice little bedtime routine away from the screens, away from the phone as much as is possible. And once people kind of start working on that, they're like, Jesus, I didn't realize how bad that was. And actually, we just do it really gradually. So sleep is one thing. And then from a nutritional perspective, I always say, look at what you can add in rather than starting to restrict. Because if you're starting to restrict, it's already in our brain going, oh God, I don't know about this. We'll see how long it goes for. And then we kind of, we pull back and then we snap forward. And that's kind of when that can negatively impact on the relationship with food and, the food choices that we're making. So I would say, look at what you're adding in. Okay. Can you add in some more colour into your meals? Can you add in a couple more snacks with some nice healthy fats and protein? Can you add in some more fluids throughout the day? Can you improve the sleep, add in more sleep? So it's what you're adding in rather than trying to take everything away.
Love that, Jess. And if someone wants to learn more from you, where can they find you and everything that you do?
I'm mainly on Instagram. I haven't veered over to the other apps. I'm not able. So I'm at willow_nutrition. My website is willownutrition.ie. Very easy to find. And that's mainly where you can find me.
Amazing. Thank you so much for sharing all of the information with us today. Really looking forward to learning more from your page as you continue to share all the updates, because we're always learning.
Always moving.
So thanks so much for joining us today, Jess.
Thanks so much for having me, Lauren. It's been a pleasure.
Thank you so much.
Thanks.
Thank you so much for listening to the Wellness Script podcast. I hope that if you've listened this far that you really enjoyed today's conversation. And I hope that you subscribe or follow wherever you get your podcasts so that you never miss another episode. It really helps the show to grow and make sure that we can continue to have these fabulous conversations about your health and wellness. And don't forget that you can download your free episode guide at wellnessscriptpod.com, where we've pulled together the key takeaways, practical tips, and important points from today's conversation, so that you can come back to them whenever you need. Until next time, take care of yourself, and I'll see you in the